We're excited to see this audience with us today for our third Musings panel discussion this year, which again is on the themes of applying revelations from COVID-19. And wherever you're tuning in from all over the country, even different countries, I was just on networking and I was talking to an amazing doctor from Turkey, talking to some patients from closer here to where I am on the West Coast. But wherever you're coming in from, thank you. We're grateful that you're here. We're going to explore one of the most unfortunate revelations from the pandemic. I think it's something we can probably say safely the most unfortunate revelation that many communities of color are experiencing disproportionately worse outcomes, including higher death rates from COVID-19. And of course, this disturbing reality is related to the fact that type 2 diabetes, prediabetes, and obesity are disproportionately affecting many people of color, and those individuals have been most at risk from COVID-19. Never before has our country paid a steeper price for inequities in health, and as that reality has been made more clear, never has health equity itself been more present in our social discourse. So let me suggest that amid the pain and suffering, there is also an opportunity. And the fact that we're having an opportunity to talk about health equities, health inequities, to talk about racism, to talk about all of the things that are changeable or modifiable. Again, I'm really grateful that all of us are here. The disparate effects of COVID-19 combined with the Black Lives Matter movement has created this opportunity for us to examine really what we need to do as a country about health inequity, and to narrow that down for our purposes, what we need to do as a diabetes community to ensure better outcomes for all the members. Without a more equitable way of looking at care and prevention in diabetes, we won't get the outcomes that we want, and we won't get the outcomes that we need. Unless all of us are doing well, none of us are doing well. Toward that end, I'm pleased to be here with three experts who are really devoted to improving short and long-term outcomes for all people with diabetes, and to do it through this amazing set of lenses that they look at the world through. What we're going to talk about here, that doesn't just obviously have to do, as people with diabetes, this doesn't just have to do with what our glucose levels are, but, as we have been talking about in other sessions, to really improve, or other musings, afternoons and evenings, improving outcomes means way beyond that, meaning we're well, we have kidney health, we have heart health, we have brain health, we have health in our emotional well-being, we have mental health, all of these areas. And I'm used to calling them complications, but we've really moved to, how about if we talk more about health and more about what we want for everyone, all of the possibilities to improve there. And that's a really big conversation. And I'm so excited for you to learn even more about that. I know a lot of you know a lot about it, and some of us are more at the beginning of our journeys, but this is going to be an amazing conversation where you're going to learn from some real gurus on this front. I just have a couple of quick reminders before I introduce the panelists. If you're not familiar with Hopin, here's how it works. Just please use the chat on the right-hand side of the screen to communicate with us. We want to hear from you in the audience, just as we have in the past, through chat, through asking questions. You can ask we're really excited for you to ask questions by putting them in chat. If you have a technical issue, for sure, put that in. And we're really interested in your comments about the discussion. And so please use that. And remember, if you write something in chat, everyone will see it. I know everyone will be respectful and courteous, just as been the case in the past. At the top of the chat window, you'll also see a tab for polls. We're going to post questions there throughout the event. And so go ahead and try it out right now. And just start by telling us where you're tuning in from and what your relationship to diabetes is. Thanks for participating in those. We hope that you're going to join us back in the focus sessions after the panel, which will stay open. If you can't stay for the whole discussion, it's being recorded right now and will be circulated to the diaTribe readers. So please sign up at diatribe.org/join if you're not a subscriber already, and we'll hope that you will share it too. And anyone who wants to put this on their own social media right now, it's diatribe.org/musings. You can start there to get the link to registration. It'll be open the whole time. Our incredible community manager, Cherie Shockley, will be live tweeting throughout the panel. It's #diaTribeMusings. And please join the conversation on social media, if not in the middle of the event like she's doing afterwards. You may have seen the pictures circling about our speakers. Their social media accounts are also super easy to find if you just go to @diaTribe News, our own handle on Twitter. And as always, my heart just goes out to everyone who is making these gatherings possible. Our sponsors have done so much to be here in community. Many of them are patients themselves, and they want to be talking to more patients. If we were all here in person together, their names would be up in lights. Thank you to our gold sponsors, Abbott and AstraZeneca and OneDrop. Thank you so much to our silver sponsors, Dexcom and Sanofi, and our bronze sponsors, Insulet, Lili, Medtronic, and Novo Nordisk. Again, it means the world to us what you're making possible as a nonprofit. So we're going out to nearly 250,000 people every week. Thank you so much for helping us and grow that number. And and just again to all of our sponsors for helping us. You're basically making it possible that we're having these conversations, and that you have told us how important it is to be listening. And you're totally right. So you're giving us the opportunity to listen, and then to learn, and then to write, and then to learn more. Tonight, we're going to learn a lot more. We're going to listen a lot more. And, thank you to diaTribe for our small but mighty team for moving online with these discussions and bringing what I know will be really compelling insights and perspectives that all of us are going to hear this evening. So without further ado, I'm really thrilled to welcome these amazing leaders and to learn from them so much more about health equity, diabetes, public health in general. First up, Lili Valletta, the co-founder and CEO of CIEN Plus and Culturintel. Lili's a powerhouse. She's an award-winning entrepreneur, a World Economic Forum Young Global Leader. As an immigrant from Colombia, she came to the US at the age of 17 without speaking any English. She embodies what many people have traditionally thought of as the American dream. And we're so excited, Lili, to bring your breadth of knowledge into this conversation. Thank you for being here.
Thank you.
Next, we have Conrod Kelly, and he's who introduced us to Lili. Conrod's an executive director of policy and government relations for Merck. He runs social determinants of health there. We're excited to see him in that massive leadership position, and it sure is. And so excited to learn from him tonight. His position is one that we would love to see at every Fortune 100, every Fortune 500 company. And, in his role at Merck, Conrod oversees developing and testing really innovative approaches to help strengthen health systems and reduce disparities to dramatically help patient and population health outcomes. So Merck has come a long way in helping people with diabetes. I love thinking that they brought everybody medicine that didn't make people with diabetes lose weight back in the day when they engineered and innovated and brought Januvia. They have been so focused on everyone with diabetes doing better. And Conrod used to run a big part of that commercial organization before he moved over, and now has this huge responsibility on social determinants of health. He personally is one of our most very valued partners at diaTribe and has been working with us for a bunch of years now. He also got this really cool honor, the top 40 under 40 by Medical Marketing and Media. Conrod, welcome. It's amazing to see you here.
Thank you, Kelly. Looking forward to the discussion.
Yeah. And so am I. We have had some really interesting discussions coming up to this, Lili and Conrod and Michael Currie. So finally, he's the third panel member that I'm going to bring up here. He's a new friend for us at diaTribe. He's also got a really big job. He's Chief Health Equity Officer at UnitedHealth Group. So what's UnitedHealth Group? I know you all know what it is, but just to underscore, it's the nation's largest health insurance provider. It's a big deal. He's led the coordination and management of health equity efforts across UnitedHealth Group for over 10 years. All of this stuff is super, super important to him professionally, very important to him personally. He has a massive passion around health equity and has held roles really both on the public and private sectors with responsibilities on disease management, on wellness, on health benefits. He spent close to 30 years educationally and professionally focused on population health management. We're so honored to have him with us today and to include a voice from an incredible payer, UnitedHealth Group. Michael, So excited to see you here and to be with you and Conrod and Lili. And I'm going to give you the first question, just like we said. I have learned so much from you, Michael, just over the last few weeks. I just want to hear, health equity, whether we're talking about diabetes or otherwise. Just what is it? Start us out.
Thank you very much for that very kind introduction. It's a pleasure to be here and be on this panel with such esteemed colleagues. When we think about health equity, simply put, is the opportunity to live your healthiest life possible. Whatever your abilities or disabilities are, it's the ability to receive tailored and unique programs and services to help provide you or allow you to, again, live your healthiest life and drive the healthiest outcomes possible. Now, let me give you a visual. Those are words, a visual. So think about bicycles, and if bicycles would help you live the healthiest life possible. In this definition of health equality, equality means everyone would get a bicycle. It would be the same size bicycle, it would be the same speed bicycle. But we know individuals have differing abilities based on size, gender, age, and disability status. And that's where equity comes in. Health equity means providing individuals, or those individuals in this example of bicycles, with a bicycle that is tailored to their unique and specific needs. So if you have a disability, you receive a bike that accommodates that disability. If you're tall, it's a larger bike. If you're smaller or of a younger age, it's a smaller bike. So if you think about that visual, it is being able to access and then utilize programs and services that allow you to live your healthiest life possible, regardless of condition, disease, or anything else.
So I just got chills. In diabetes, I don't think that we even know that is possible. Over to you, Conrod. What are your thoughts on this? How's the conversation around social determinants of health changed in recent years?
Sure. So I think in recent years, there's been an increased recognition that improving health and achieving health equity will actually require a broader approaches that actually address the social, economic, and environmental factors that actually influence health. And so social determinants of health, by definition, are the places in which people are born, they grow, they live, they work, and they age. And they also take into fact those factors like the socioeconomic status, education, the neighborhood and the physical environment, employment, social support, and even access to healthcare. And these are all things that drive health outcomes. One of the most important things around social determinants is when you list off those things, I think people typically go to the negative. But that social determinant of health are just the factors. So just like how a lack of access to food can lead to a negative outcome, actually having access to healthy foods can lead to a positive health outcome, similar to education or healthcare. And so I think what's important for people to keep in mind is that the social determinants of health are not necessarily negative or positive. They are factors, but when we do talk about them a lot, it's more about those people that have health disparities or health inequities. And these social determinants are typically the factor that drive to those outcomes. And I think what I'll say on top of that briefly is just, oftentimes when we think about social determinants of health, the first thing that comes to mind is like, well, this must be the poor community or the uninsured community. There's actually a recent survey done by McKinsey that said 48% of their respondents were actually impacted by at least one social need. And in fact, in the last year, about a third of all Americans were impacted by a social need that actually was a barrier to them achieving health. And so the last thing I'll say is that while social determinants of health gets kind of a lot of the airtime, it's important that we're very specific when we're talking about this topic. And so we need to introduce the concept of social need, social risk, and then social determinants of health. So let me give you an example. if a social need is someone that has an immediate need. So if I need food, I need housing, right? I am homeless or I am food insecure, I need that. Whereas a social risk is more an adverse condition. So that may not mean that you have that need, but you may, for instance, live in a food desert, which means that there's a high likelihood that you may not actually be able to gain access to healthy foods. Now, the social determinants of health are really driven by the economic, the social, the political factors that created that disparity in that community to begin with. And so I think it's important as we continue this conversation, it's important for people to understand the difference between the social determinants, the social risk, and then the social needs.
Yeah, social needs, social risk, we are getting this whole download. And whoa, Lili, when you think about social needs, social risk, how do the shifting national demographics and the disproportionate impact of COVID-19 on people of color, how does that put pressure on our healthcare system to be more equitable? You can follow on to where Michael and Conrod have started us. But
yeah, absolutely. There is one compelling number that I want everyone to remember. It is jaw-dropping, so take note. It's been well documented that upwards of 80% of all factors that drive a good outcome in health are related to things that are not clinical care or medical treatment. So let me say that again. 80% of the factors that drive somebody's good outcome have something to do with other things that are not medical care or clinical, treatments. Now, when we look at where we put our monies today, where we invest in healthcare, 88% of our spend is going to address that little bit of the 20% of clinical care and medical treatment that is not really driving the factors that impact outcomes. So it almost feels like that formula is backwards. So back to your question, Kelly, we need to rethink and almost reconfigure our brains, both as patients, leaders, industry folks, and the fact that it is basically mathematically impossible when you do look at that correlation for us to not be investing into all the elements that will have a direct correlation to a good outcome. Now, if that is the context of factors and spending, if you add on top of that shifting demographics, which is something that we're seeing in today's new America, we should definitely even reconfigure the entire formula to be more inclusive. Well, let me give you some numbers so you don't have to get too confused with what all this means. It's a very simple number. 100% of population growth is driven by diverse segments. That means all growth in population in America is coming from all segments that are non-Hispanic white. That has everything to do with birth rates, with being a younger demographic. The average Hispanic is 27 instead of the average American being 57. So obviously it's a younger population. And if those very segments are the ones that are having worse outcomes and disproportionately affected by obesity, diabetes, heart failure, that means with those shifting demographics, we're growing as an unhealthier nation. So unless we tackle those two elements, the factors that impact outcomes and the fact that we live in a new, diverse, fast approaching majority minority nation, none of the efforts that we all have personally or institutionally to drive health equity or reduce healthcare spending or have better outcomes and promote better health are just not going to work. So it's a numbers game, if I may call it that, when you look at all these elements together at play.
Yeah, it's totally what the data is saying. Thank you for that. I want to move back to Michael and just ask, from the perspective, building on everything that Lili has just said, from the perspective of the largest insurer that there is, an incredible amount of data that you have. How do you prioritize, where you're investing in terms of disparities related to diabetes?
Sure. Yeah, Lili just talked about some, as she just mentioned, jaw-dropping data. Yeah. So you can't manage what you don't measure. So everything that we do and everything that should be done as it relates to health equity and addressing health disparities starts with the data, because the data is going to allow you to determine where the issue is and the order of magnitude that it exists. So we use the data that we have on clinical outcomes and member demographics to put those two together across our various lines of business, commercial, Medicaid, and Medicare, to evaluate and assess where health disparities exist across a myriad of health outcomes and health metrics at a population and demographic level. So we'll take those outcomes and stratify them against age groups, genders, geographic location. When we have good self-reported race ethnicity data, we'll use that information as well to allow us to identify those health disparities, prioritize them for action, and then begin to develop our action steps, both action steps that we'll take internally on our programs and services that we deliver, as well as programs and services where we partner in local communities and in geographic areas with providers, federally qualified health centers, community-based organizations, and others. So that's how we leverage data every day, all day, to drive our clinical insight and operations and activities, to then deploy initiatives and interventions and engagements in the most cost-effective way.
Yeah, wow. It's been really cool to watch United over time. Even just some changes that United has been focused on recently with level 2 and with CGM, and who gets CGM, continuous glucose monitoring, and all of that, and helping data make everybody smart. I'm wondering, Conrad, given that Michael's talking about the data and how important it is to be looking at that and stratifying the data, what would you say is the most impactful work you see being done to address and create health equity? And I'm talking broadly speaking.
Got you. Well, first I want to piggyback on something Michael said, because he really outlined a great framework for doing this work. And I think some might wonder, well, what is a pharmaceutical company doing in the space of health equity? Well, our approach is similar. And we've really organized ourselves around data, partnerships, and policy. And so I think that, there's opportunities to be able to leverage a lot of this data that's being captured in various data sets and EHRs to be able to understand where there's opportunities for us to actually engage more at a local level, because so much of health happens at the local level. And as you start to be able to stratify the disparities, you start looking at the epidemiological data, you can start to understand how I need to approach this differently in the space of cancer, in the space of diabetes, in the space of immunizations, because there are geographical differences. And so while there might be limitations in what we can do from an intervention, that's the importance of partnerships. And so you start to identify different partners that exist, like Health Leads or the Unitas of the world, that are offering this tremendous service of being able to map that community-based care organizations, so that once you screen and identify a patient, as Michael referred to earlier, you now have a resource that you can connect them to really be able to help them address whatever that social need might be. And then lastly, like as I mentioned earlier, so much of this work does revolve around policy. And I think a lot of the work that you've seen happening has been the result of collaboration outside of public health. And I think that's the most important concept, is that if we really are going to be successful in achieving health equity, we have to start finding unique partners to bring into the fold to really be able to work together to tackle this issue. But I think those partners, especially those corporate partners, even outside of healthcare, they have an opportunity to be able to advocate for certain policies that support this. Because I think what COVID has really brought to the surface is this notion of essential workers. And I think we see that when all people in America and across the globe don't have access to care and they're not healthy, we see the impact that it not only has on families and loved ones, but we also see the impact that it has on the economy. So what I will say is that, we've seen great examples from insurers. We've seen great examples from hospital systems, but you're also starting to see, this cross-sector collaboration and finding some new partners, especially as you start thinking about the opportunity to really address this from a systemic issue. And I think this word systemic comes up a lot in the current discourse. And so as an example, whether it's policies around public transportation. Kaiser and Bernard Tyson were very prominent in being able to change a lot of things in California as a part of their work around social determinants, as they identified some of the issues with transportation as a means of access to health. They also made investments around employment opportunities, which is also something that's now supported as a result of the ACA within Medicaid and some Medicare plans as well. You've seen advancements around the nutrition programs. You've seen the rising number of food insecurity and people having to go to food banks as a result of what's happening as a result of this crisis. And then education, right? Every parent is trying to figure out what are they going to do if schools are open back up. Well, early childhood education is extremely important, and it is a social determinant that has an impact on health. And so I think this is such an important moment where people start to see that it's not just healthcare, it's not just health insurance or public health, but I think everyone has an opportunity to be able to get involved and advocate for those policies that can help to reduce those systemic barriers that are feeding the health inequities and health disparities that we're seeing now.
Yeah, and in thinking about you're just talking more about resources and all of us doing some learning. And I love when I hear you talk about the partnerships outside of healthcare, getting everybody to a level place, even where we all know the language. So we posted a few minutes ago, and I just wanted to highlight this. Two really great pieces that Lili gave us, learning that is going to help everyone you want to share it with, learn more about social determinants of health. And there's also that is just a really fantastic infographic from Lili's company, CIEN Plus. So, just wanted to think about that a little bit more. There's obviously like a lot of learning that has to also go on and happen on cultural competency. Both of girls, their teacher, their head of their school, Wanda Holland Green, always says like cultural competency. Yeah, that's like should be taught like math. And there's so many people that are trying to do that. Not everyone yet, maybe. But Lili, what are some ways that cultural competency needs to change to lead to better outcomes? Where is cultural competency maybe not as much the answer? And maybe just define it for us to start with.
Absolutely. And I'm going to go off script for a second, Kelly, because I can't help myself with something Conrad was saying in terms of the data and kind of reimagining who are partners and where that data comes from. There was something that I actually heard firsthand in a big, healthcare and pharma Davos panel earlier this year. And it really stuck with me because one of the panelists looked at this room of very high-ranking pharma and healthcare executives attending the Davos, World Economic Forum meetings. And he said, we're not going to get healthcare right until we, meaning we, the healthcare people, realize and are humble enough to understand and acknowledge that Netflix may know our patients better than we do. And I will never forget when he said that, and kind of mic drop, the room was very silent. It's like, he just said that. And he wasn't just trying to be shocking. It goes back to the fact that there may be data in your Amazon card or your supermarket loyalty card that gives us bigger and better clues about anticipating health outcomes that our EMRs may not be telling us. So anyway, I just wanted to put that out there because to me, that comment was very profound and I carry it with me. And it really keeps me humble too. There may be other things and patterns that really tell the full story of the human being. So anyway, back to understanding the full human being, to your question, Kelly, on cultural competence. I like to codify that as cultural intelligence because cultural competence almost sounds like a class that I attended and I learned something and now I'm storing knowledge in my head. But when cultural intelligence is part of you, it's kind of like what we've heard in business schools that you got to be an emotionally intelligent leader. You got to have, CQ, EQ. And I'm saying you need this new level of intelligence because in today's fast changing marketplace, we have to be able to be aware of, understand, and apply cultural competence and data into the way we make decisions every single day. And again, if cultural competence or the understanding of the factors and elements that are levers to good outcomes or to promoting health equity are not taught upstream, let's say with the healthcare community, doctors, nurses, PAs, MPs, then when they come to serve in this new diverse America we live in, you're going to miss some tools in your toolkit. So it is this inclusive approach to everything you do, and that takes a different lens. And I'll give you a very practical example. This is almost going to sound so mundane and simple, but it's the kind of stuff you would learn, let's say, in medical school, bedside manners, how to treat, let's say, Hispanic patients, like me. It is very likely that a Hispanic patient, let's say 65 plus, it's going to come to an appointment with a relative, a daughter, a niece, a neighbor, and it's very likely that that person is probably the one that is more proficient and comfortable with English. So if I have been trained with the cultural intelligence to know when I am giving instructions to a Hispanic patient, let me ask the question, hey, who did you come with today? It's very likely she or he is going to say, oh, my daughter is in the waiting room outside. Could you please tell her to come in? And all of a sudden, you are ensuring the likelihood of a better understanding, follow through, and outcome. Because for Latinos, health is about we and not me. And decisions are made in a communal way. We're not going to ask the doctor because he or she is the authority figure. You're intimidated. Therefore, as a practitioner, if I am trained with these cues of cultural intelligence, I will know to ask that question and very likely secure better understanding and a better outcome for that particular patient. So things like that, again, that sounds very simple, very inexpensive if you think about it, are the kinds of things that come with empathy, authentic connections, and knowing what are those levers that impact these persons' culture, context, people that influence him or her, so that I can pull those levers at the right time to better secure a good outcome or understanding. So absolutely, it's missing. You just said it, Kelly. It should be taught like math or anatomy or biology, because there is no other way. It's not about diversity training, but it's about training to serve a diverse America, and that's fundamentally different.
Yeah. Although some kinds of training are also really good, I guess, on the diversity front to get everybody to the same starting point. Maybe everyone isn't. Michael, I think I didn't go back to ask the second, or maybe ask you to answer the second part of that. As Lili is, and I'm just reminded by all of what Lili is talking about in terms of cultural, what did you say? Cultural identity, right? Was that right? Cultural, not so much intelligence. And hopefully that will be just all the normal thinking that everybody has. But Michael, can you maybe talk more, as you have in some of our planning, about changes that you think maybe could be made once we know more, or where are the places where we need to know more? Where we need to learn more.
So Kelly, the reality is there isn't a place where we can't do better, learn more, and drive better results. This is going to continue to evolve. This is a journey. This is not a sprint. This is a marathon. As Lili mentioned earlier, or may have mentioned earlier, this is about a mindset change. And that mindset change is going to be moved by a number of different factors. Some will be just intuitive to folks. Some will be associated with directives. Conrod has talked about policy. So some will drive, some of it, the driving force will be regulatory in nature. So there are going to be multiple levers that move health equity and addressing health disparities along. One of the things I want to point out is this notion of health equity, because sometimes I think there is this interrelationship in discussion between health equity and health disparities. So let me see if I can put this in context. Health equity is the top of the mountaintop. It's the overall goal that we all want to achieve. In order to achieve health equity, there are a number of tools in the toolkit that you use to achieve that health equity result. Addressing health disparities, better risk stratification, driving health literacy, addressing social factors or social determinants of health, tailored materials, cultural competency training. There are a whole host of different tools in the toolbox that we will continue to evolve around, get better, smarter, faster, stronger around. And hopefully, if the Mikes of the world, the Lilis of the world, the Conrods of the world, the Kellys of the world are doing our best work, we're going to embed this over time into just the natural process and flow and thinking of how organizations that are involved in healthcare do their work. It's just going to be what is. It's not going to be necessarily something that needs a chief health equity officer. It's just embedded in how we do what we do.
Yeah, whoa, how we do what we do, and those would be all of the right things. I just want to pause for a second just to kind of share with you, we're seeing so much in chat that's really interesting, and just to say that the audience out there, we're so happy all of you are here. It's about half people who have diabetes. About 15% of people have loved ones with diabetes, a bunch of healthcare providers, a bunch of people working in the field, and so forth. What I've been really struck by is, and people are saying this is great because they don't necessarily understand the concept of healthcare equity so much. About 25% understand it very well, but about 43% would be in the like somewhat or not well. And then for how well people understand social determinants of health, that's about approaching 45% not well or somewhat. We got some cool people here too who understand it very well, or well, about half. But listen to this. So have any of your healthcare providers discussed matters of health equity and equity with you? I know that I said no, and that the no was approaching 90%, and 89% of people said no. And so it does go back to what doctors are getting in training and what is prioritized and all of that. But I hear you all about getting to a place where cultural intelligence is just how we all live. Conrod, if you can kind of build on some of what Michael was saying, he was talking about like some stuff that's happening at the local level, education, food, elsewhere. But what policies are you kind of seeing? Maybe it's at the state level or national. What is working? What kind of policies would you recommend to achieve more health equity? Is there anything that you think people listening right now can do to advocate for change even more, along with making sure that we're all talking about this as much as possible and as a culturally intelligent way as possible? Culturally intelligent.
As I was looking at some of the comments from the individuals on the event, someone mentioned, universal health care. And I think that's something that has to be a part of the discussion. And they mentioned it being more of a human rights kind of a discussion. And I think, this idea of universal health care is important. I think also this notion of thinking about health in all policies, because you can't forget that data once you hear it, that Lili mentioned, that 80% of health outcomes are driven by non-clinical factors. And so that means at birth, you have an opportunity to start building a culture of health in those families, in those communities, in those schools. And so when you think about it, from a policy perspective, there were good things that came out of the Affordable Care Act, the creation of the Center for Medicare and Medicaid Innovation that created accountable health communities. And they started connecting Medicare and Medicaid beneficiaries with community services to address some of these issues. Some states that did expand Medicaid are actually providing housing for individuals and employment support. And while it's this notion of it's better to provide a care for them in their homes than them using the emergency room as a place to be able to get a meal or to get shelter. And so you're actually keeping them out of the hospital so you can actually drive costs down. As a part of the Affordable Care Act, not-for-profit hospitals had to create, and not create, but they had to conduct community health needs assessments. And so once every 3 years, they had to look into the other communities where they're the anchor institution to think about strategies that they can come up and implement to be able to meet these needs. And then I'll say lastly, from a provider perspective, there's a great tool out there, the Prepare Checklist, and Health Leads also has a great tool that really helps providers ask questions in a way that you're not re-traumatizing people, because I think that's really important when you're capturing this data. But it allows you to be able to identify these health-related social needs, capture it, and so that it's documented. And then, like I said, there's been such an advancement of tech companies like Unitas, like Healthify, like NowPal, like Health Leads, that have made it so much easier to be able to connect people to these resources. And so I think there are things that are happening. I think there's some small scale, innovations and ideas that have been implemented that need to be shared, and they need to be talked about, and they need to be celebrated. And then you need to think about how can you duplicate that. But I also saw in the chat, which is really important, is that you've got to be able to get into those communities, and you've got to be able to build trust. And I'm saying that from, representing an organization where, as an industry overall, we may or may not have the best relationship, but this is what we're doing by creating a dedicated role, is making an effort to be able to get into these communities, sit down with different partners, leveraging our influence to be able to support policies, and then thinking about how we can better understand what's happening at the community level. Because I think it's very easy to sit in these big organizations and think you can come up with these ideas to be able to solve other people's problems. But if you don't know their history, you don't know their lived experience, you don't know the policies and the environmental factors that created it, you can't just lob solutions over the fence and think they're going to work.
Michael, Lili, any thoughts on this? We're going to go to some questions from the audience in a couple minutes, but yeah.
I'll just add something real quick, because this may be very daunting. We hear all the stats and there's so many gaps. Again, I like to be practical. There are some simple interventions, like it is estimated, and maybe that has gone up during COVID, but that about 24%, so that's like 1 in 4 hospitals are already screening for things that are other things that are non-clinical related. So it really starts with those protocols of what is it that I'm asking and what do I do, like Conrod was saying, redirecting to services or partners. Maybe your best ally for driving better outcomes in your community has to do with teaming up with the YMCA and the local churches. So it really is reimagining the places and spaces that drive better health and picking those up, or those cues at the point of care, like I just said, with the 1 in 4 hospitals already embedding some protocols that ask other things that are not like the obvious medical things. That is already a good start, and is also for us as people to start reframing what is it that is getting in the way of my good health that may have nothing to do with the traditional, thinking of, am I controlling, am I adhering, am I checking and monitoring, because there may be other things getting in the way. So it's an integrated approach to the whole person. And that's how we start making a difference.
Yeah, it's interesting that you say that. I think so much of diabetes is going toward those. So we don't need to think about monitoring. Like, we don't need to think about these things as much, because they're like, if we're taking medicine that doesn't give us hypoglycemia, that is glycemic dependent and doesn't get in the way, or, having medicines that are better and actually have fewer barriers associated with them. I know we've come so far on continuous glucose monitoring, thinking about doctors using it more to be able to identify interventions that would be really valuable. I want to say I love hearing from the audience out there. Julia from my team posted, just a question about where do people listening think that the best things that they are seeing are happening. And we want to hear from everybody on this. We want to hear from you a little more. You can share that in chat. There's also a question from Hannah in the audience. What are some ways in which I'm so psyched that she's asked that physicians in particular can better treat patients of lower socioeconomic status, both at the individual level and perhaps even practice-wide. That's exactly right. What would you guys say on that, or what advocacy work she's asking would you like to see? What are the gaps in care that are possible to address right now, even before more national policy, before we get to national policy?
Yeah, I'll speak to the first part. Two levers or two opportunities. One or both of them are already in play, not just at UnitedHealthcare, but with other healthcare insurance companies as well. One is the continued promotion and encouragement around cultural competency, cultural awareness, cultural sensitivity, cultural appropriateness, culturally intelligent training and education. I like that word, Lili. I'm going to use that. Really being able, and in its barest form, what that allows physicians to do, whether or not the training happens in medical school or post-medical school, it allows them to listen and communicate in a way that takes the person, we call it person-centric care, but takes the person into account so that whatever the dialogue is and whatever your recommendations are specific and tailored and personalized to that individual and the realities that they have presented to you. So that listening and communicate, whatever it is we are going to call it, that listening and communicating in a more compassionate, sensitive way is one element. Another is home-based care. We know that there are these social determinants and social factors that disrupt access. And one of the ways that we can mitigate that disruption in access is home-based care. Now, obviously, we can't do that for everyone and everybody, but when we leverage data to prioritize those individuals that are at the highest risk, whether that's risk based on clinical outcomes, risk based on social need, risk based on genetic or biologic factors, being able to leverage home-based care in a more meaningful way to drive better health outcomes and reduce unnecessary and avoidable costs are two things that are going on now. And I feel from when leveraging a health equity lens will do nothing but evolve and expand over time.
Yeah, there is so much there. I wonder if you I wonder what you think of some of United's work. It's been amazing to see you guys, expanding and leveraging care. There's probably not a huge, maybe I should ask all of you to just talk about the field, but there are so many ways, again, that better care, better interventions have become easier. And that's not always true, I suppose, in the medical system. But what do you think about some of that? Whether it's, easier therapy, easier technology, and then marrying that data that's coming out of it toward the better interventions.
I'll kick it off, and then I'd love to hear what Conrad and Lili have to say about this. I'll mention a couple of things. We're obviously going to continue, all health insurance companies, this is not specific to UnitedHealthcare, we're going to, and pharmaceutical companies as well, I'm sure Conrad can speak to this, we're all going to leverage technological advancements, whether it's improvements, leveraging technology related to retinal exams, to insulin pumps, whatever it is, we're going to leverage technology that allows us to better treat individuals and drive better health outcomes. Now, another area that we will continue to focus other than technology or in addition to technology is our own research and development. We're going to continue to do research and development, whether it's small pilots, large pilots, or large scale research type of activities to learn what we need to learn or learn what the healthcare system as a whole needs to learn to improve treatment over time. I'll pause with those two and see what others, I could go on with some others. I'll stop there and see what others, Lili and Conrad.
One of the ones that is kind of a hot topic right now is the use of telehealth and telemedicine. And I think this gets back to this conversation again around health disparities, because on the surface, telehealth sounds like a great solution. It tackles one of the issues, which is transportation. But on the flip side of it, you then have to understand that there's widening gaps in care amongst these diverse populations, because not everyone has equal access to broadband, to internet, to computers, to be able to fully maximize the capabilities that telehealth offers. So yes, it's better than not having it, but you have to now think more broadly and think about, man, how do I now make sure that while we're trying to get people signed on and to partake in telehealth, we're making sure that because of their, socioeconomic status, it doesn't become a barrier to them actually being able to receive care. And so I think that's just one of these examples of where you have to think, a little bit outside of it, that the fact that while you're creating one solution, you might be uncovering another problem, which I know can be frustrating, but it's just about this idea of how do you bring another partner to the table. And a quick sidebar here in Philadelphia, Comcast just rolled out a program to make sure that all the kids that need to do remote learning can gain access to broadband. And so I think there are things that these private companies can do when working with public health to be able to tackle some of these systemic issues that can once again remove a barrier to being able to gain access to the resources needed to achieve, as Michael said at the top of the pyramid, health equity.
Hey, Lili, I'd love for you to speak to leveraging digital technology and digital advancements in a more meaningful way. I just want to add to Conrod, made me think when you mentioned remote patient monitoring. And remote patient monitoring is great. It's great. But there are two pieces of remote patient monitoring that need to work in order to make it great. Number one, the provider has to have this technology and resources to be able to access the remote information. And then secondarily, the patient needs to use whatever the technology and equipment is so that the provider can get the information. If the patient doesn't use it or doesn't send the information in or doesn't have good connectivity so that the information flows, then there's a disconnect there. So it plays to what Conrod talked about, that connectivity in telehealth. It also relates to remote patient monitoring as well.
Absolutely. And I'm actually going to steal a term from somebody that just put it in the chat here. There are internet deserts. And if you add on top of that the layer of background, ethnicity, those inequalities are more pronounced. Like, just to give you some of the numbers so you realize the gravity of it. While we're so excited that the uptake of telehealth has basically doubled during the COVID season that we're living in, well, at the same time, the digital divide that was already impacting those patients that are disproportionately affected by diabetes by 2x, and also heart disease and obesity, so Hispanic Americans, Black Americans. Well, let me give you some of the numbers to put in context. So the digital divide amongst the Black community is estimated that about 43% have no access at all to broadband or very, very limited. So that is that's a very high number, 43, and it's 38% for Hispanics. So if all of a sudden the very patients that are already disproportionately affected by diabetes, and by the way, in this season of COVID, we have seen that when a diabetic patient gets COVID, is 4 times more likely to actually die of that disease. And all of a sudden, that happens to be also the patient that has no connectivity, therefore even more limited, abilities to get that remote care or to check in with the doctor. It just becomes like this compounding effect of factors that just make the likelihood of a good outcome very, very slim. So you're spot on. There's all these other things beyond just assuming or stopping by looking at the data at telehealth has doubled during COVID. Great, a blessing in disguise during COVID. But if we don't understand the personalized data, back to person-centered interventions, this is people-centered data on digital access, we may be missing out on the fact that that uptick of telehealth may be counter to the very groups that we need to serve differently. Now, what that says, which again makes us all scratch our heads, and that's why we do what we do every day in our different roles, it's then we're going to have to reimagine the solution. Is it the rekindling of community workers, health promoters, church leaders, health ministries, diabetes navigators, just as we have them for oncology? I don't know, or all of the above. Because with that digital divide and telehealth being so popular, we may be continuing to leave behind the very people that need it most. So that's the stuff we got to look at in a holistic way.
And Lili, if I can just chime in quickly on something you said, and it was brought up in the chat, and I'm a big supporter of this, is this notion of community health workers. And so I think people are starting to also, see the connection between you got a lack of trust between the community and the healthcare industry, but then you've also got these other factors that are limiting people's ability to be able to engage in the healthcare system. And so I think there's a unique opportunity there to really be able to hire people from the community, train them, provide scholarships to become community health workers so they can be that bridge between the community and the industry. And not only are they a bridge, there's an opportunity to get insights, to have people from the community have a seat at the table, to really be able to shape how organizations are executing, how they're implementing, how they're building out their plans in a way that's also sustainable. Because I think while we're all in the business of turning a profit, we also have a responsibility for sustainability and a social responsibility. And so I think that there's just a unique moment in time right now that I hope that this movement of COVID and Black Lives Matter, it's not about a moment, it's more of a movement, and I hope it's sustainable. And that while these organizations are doing these big kind of gestures, that they think about how they can evolve their organizations, how they can hire people from communities, how they can improve diversity and inclusion. And so that you're also putting money into the community by the hiring people from the community and not just writing a check. So you can start to change the culture from inside out.
Mm-hmm. Yeah, it's interesting. Sorry, go ahead, Lili.
No, I was just gonna kind of give you my elevator phrase, which I think Mike alluded to, for all of us to remember, those of us that can influence our community or our families, our churches, our practices or businesses. It's this notion of inclusion, which ultimately is what drives an inclusive lens to how we make decisions and design systems, solutions, policies, right? Inclusion and diversity, which is so hot these days, is not a program, it's a mindset. Mm-hmm. So it is not a program, it's a mindset. And that is not because you have us here that represent the community saying it's important. It's mathematically impossible for us to reduce cost of healthcare and get better outcomes in this country unless we have an inclusive approach to healthcare because of shifting demographics, what we see in incidence rates, and all of these different factors that are disproportionately affecting those that are driving population growth. So again, it's a mindset and not a program. And that is a big hill to climb, but with all the stuff we're seeing, there's some awakening, the disproportionate impact during COVID, the marches, the George Floyd incident and others. This is not an altruistic mission. It's just the only way for being effective and healthy in a new America. So that's important because it's a mind shift. It's not the people with diversity in the title that carry this load.
Yeah, I totally hear you. I want to bring in some of these questions. Yeah, but George Floyd, death, say it. And I want to get it back to also, but like circling that back to who's doing the treatment. I mean, it's a labor of love. Like being an endocrinologist, working on heart health, working on kidney health. being a primary care doctor, you know, and I was trying to pick up some of what Carol was asking out there, you know, the recommendations, they do sound really well. And then there is this whole thing of compensating physicians and, you know, how do you do that when they need to spend more time with patients to facilitate these changes? I love what you were talking about, like remote monitoring and the home-based care, and kind of her whole question, really, like balancing quality and cost. And it's Tara Smith is asking along those same lines. I just want to kind of bring you some of this audience questions because they're so on target. But you know, she's coming in from project manager from Beyond Type 2 is a total powerhouse, what she has been making happen there. But she's saying, like, can you list some more examples of home-based care providers? You know, during the pandemic, it was great to hear you guys start to talk about telehealth and all of that. But yeah, maybe just some more on the remote-based care, like remote-based monitoring. What do you mean? And do you think our healthcare providers have enough time to do it and enough training to do it? We could start with you, Michael, if that's okay.
Sure. Is there enough time to do it? Yes, because you can leverage technology in a way that you couldn't a year ago, 2 years ago, 3 years ago. How or what the uptake is going to be more on the patient side. Again, I don't believe that for the majority of providers. I'm sure there are going to be some providers where having the resources to leverage telehealth and remote patient monitoring in a meaningful and sustainable way may be somewhat of a challenge. We want to be there to support those providers. But overall, I don't think it's that much of a barrier on the provider side. Now, on the patient side, that's a different story. Because again, the connectivity is going to need to be there. Folks are going to need to know how to use the remote patient materials and supplies and equipment that are provided. So there may be more of a learning curve on that side. And because as Conrod had mentioned earlier, there needs to be a trusted relationship with the provider. So we, the insurance company, don't want to disrupt that trusted relationship that an individual has with their provider by injecting the insurance company and some level of support that we may feel we need to provide. So there's going to need to be a nice balance there of how that's executed so that it is impactful and sustainable.
And Kelly, you know, the one thing I'm surprised hasn't come up, and so I'll go ahead and bring it out, is just the role of racism and bias and prejudice, especially in the healthcare system. And, you know, it's something that makes people uncomfortable to talk about, but, you know, we've seen it. We talked about data. We've seen bias hardwired into the algorithms. We've seen, you know, data that cause certain groups to receive more pain meds than other groups. Just recently, there was a study that was, you know, floating around where a Black infant under the care of a white physician is 3 times more likely to die. And it's like, what do you do with that information when you look at the absence of representation of minorities in healthcare? And that it's so unlikely for you to walk into a doctor's office and see a Black physician or a Latino physician or even an Asian physician. And so I think, you know, on both folds, I come back to this idea of you don't put everything on the policymakers, and they can't fix everything. But when there's always like, we've got to create jobs, we should have a say in what kind of jobs do we need creating. When we say, well, we want to build for the future, well, the people in our health is critical to the future. So what is the plan for healthcare? And it has to go beyond just access to medicines. It has to evolve to creating a culture around prevention. And I've seen that mentioned in the comments, and I think that's an important topic to discuss, is that so much of our healthcare system is built around treating the illness, and not enough is there around prevention. And how do you start to build those healthy habits? And I'll give a quick example that is something you've heard me say this before, which was really marketing. this idea of fresh fruits and vegetables. Fresh. The use of the word fresh allowed companies to be able to charge more for products. And so those frozen vegetables and that frozen kale that you can get for 79 cents or 99 cents versus the fresh kale that you can get for $2 or $3, you know, people automatically are saying, well, I can't afford fresh fruits and vegetables. The nutritional value was no different. And so there's just things that we can do that we have to kind of understand history and understand how we came to this this predicament, this situation, and we have to go back and tell new stories, and we have to form a new narrative, and we have to re-educate people, because for some, the idea of buying unhealthy, fresh cooked food might be seen more appealing than frozen healthy food, where it's much more cost effective to be able to get the frozen vegetables and the frozen fruits, but people need the knowledge and then the skills of what to do with it. So I think the one thing that is missing, and I'll close with this, is that you've seen what the media and storytelling has done to impact stigma around HIV and AIDS, what it's done around impacting stigma related to the LGBTQ community. I think we need something to really do the same thing around health, and to make that something that's a part of our world culture, but definitely in the culture here in the United States, because we need it to survive. And I think COVID has demonstrated that, and I don't think this would be the last pandemic that we'll have to deal with.
Yeah, I want to get back to racism. I want to get back to racism and some of the other work that you, some of the other pieces that you were talking about. I heard your CEO, Conrod, Ken Frazier, saying, you know, how many African Americans do you think there are, you know, between 18 and 26 with high school degrees, GEDs, but no college and no job? I mean, 5.5 million. So as you talk about, like, we, you know, wanting a say about the jobs that there are and how you create all of those jobs, I mean, and that is incredible. I do think that he is really leading at the very top circles, really a reawakening of conversations around racial justice. Can you all talk about that a little more, about what else you would like to see happen on that front? Kelly Rawlings just noted, you know, that often in public discourse, you know, emotions and beliefs kind of weigh in more heavily than do data. You guys have brought up a lot of really relevant data. I mean, again, it's you're a CEO. We'd like to hear more about what you have to say about racial justice and how that ties into health equity. And then, you know, how would you guys like to see advocates get better at messaging to acknowledge beliefs and emotions while being true to data?
Well, I'll say something briefly, then kick it over to the other panelists. Someone I heard say, and I can't remember her name to give her credit, but she said, never show data without a story, and never tell a story without data. And that's always, you know, stuck with me. And I think this moment that we're in right now and what we're witnessing, I think these conversations we're having today is the first step. You know, so many people say that I don't know what to do, I don't know what to say, I don't want to say the right thing. Well, the good news is you have the opportunity to learn on your own before you ever have to say anything. And I think as we look back at our history, there's a great podcast, 1619, that talks about our history of this country and health. It talks about things like redlining and environmental issues. You look at Louisiana, there's a place called Cancer Alley that is a heavily African-American population that was really driven by policy choices and environmental choices. And so I think what's important for people to do is to be able to educate themselves on the issues. Knowing that the issues are not always universal. Some happen to do with things that are more locally oriented. And then I think it's about having these discussions and seeing how they can get involved locally, because we can always wait for things to happen, you know, in DC, but there's so much that you can do in your own community. And I think that there's great resources out there that people can tap into. So, you know, yes, you can't really disconnect racism and health. I think the public health is now starting to evolve and think about how this is captured and tracked. And I think we're all dealing with it. I mean, you think about social isolation as a social determinant of health and the impact that's had on individuals. But then you also think about the mental health and well-being when you are part of a group that is having to deal with a lot of, mental stress that could be triggered by a number of different things. And many people from disadvantaged groups, whether you're immigrant, whether it's LGBTQ, whether it's being a person of color, whether it's a veteran, a lot of people are dealing with this. So I think that's the opportunity, is to not think about this being about one particular group, but it's thinking about how do we instill some systemic changes that benefits everyone. And I did say I was going to say one last thing, which is there's a great example around ramps on sidewalks that I heard recently that I never knew about. And it was really the disabilities community that said, hey, we need the sidewalks to be accessible. Whether you're having a suitcase, whether you're riding your bike or an skateboard, we've all benefited for something that was meant to really improve the situation for one group. And I think that's something that we can't forget, that by addressing some of these disparities for a marginalized group, there's an opportunity for everybody to benefit.
Yeah, that's a cool one on ramps. Michael, any follow-up thoughts there, or Lili?
I mean, Conrad kind of went to church there on us, and there is no way to disconnect systemic historical racism and the disparities that we see now. There's just no way to disconnect those two. Now, what if we're going to do our best work, we need to understand how we got here and then work like heck to prevent us from continuing to make mistakes that allow us to either stay here or for things to get worse. And that's where champions and advocates like you, Kelly, and a lot of people, pretty much everyone on the call today, and Lili and Conrod and a whole bunch of other really, really bright minds move us from where we are now. Again, you need to appreciate how you got here so you don't make the same mistakes. Move us from here and make this look better, do better, feel better, smell better for generations to come.
Yeah, I like that. Well, I mean, the work that we get to do at diaTribe is also just because of all the patients out there, obviously, and I love it that they're telling us in the chat that they want to see even more on advocacy, and we've got something coming up, some cool work coming up that we're doing with the whole community called diaTribe Change. So be on the lookout for that. But we're really just trying to listen more. And, DQ&A is been amazing in giving us some of this data that we would not have thought, even knowing how disparate opportunities are. We wouldn't have known this. Black insulin users are so much more likely to have a supply of less than 30 days compared to white. We know that's true, but the extent to which that is true, I wouldn't have guessed. 13% of Black and Latino community members at DQ&A have rationed their insulin. That's compared to 5% of white community members, and it's, again, 4% of Latino community members, 3% of the Black community at DQ&A have been diagnosed with COVID. I think that was less than 1% of white community members. It makes me just wonder, and to go back to another question that we have from Tara, how do current providers, how are current providers better trained to change their own mindset, particularly the ones that have never had to worry about race or racial issues, she's saying, and how could that impact patient lives? Should providers be asking their Black patients, patients of color, how incidents like George Floyd, Breonna Taylor are impacting their lives in diabetes management? Wow, she's going to church on us too. I love the idea. I mean, Tara, I love the idea also that they would even have time. I do think that so many healthcare professionals are under a lot of pressure, but so that they're learning in med school and in nursing school and all of that, taking the time to do that, taking the time even to say, how are you? But what do you think about that? You're all data gurus, but especially Lili.
Mm-hmm. I think we get scared of the questions or talking about the subjects because we give labels to it, right? If I go the George Floyd way, is that going to turn political? You know, I don't know where your practice is. If you're in New York or in LA or in Louisville, Kentucky, or in Salt Lake City, it's going to be very different. But I think we need to rise above that, is just the profound questions that we know have implications on anxiety and mental well-being, and the context of a pandemic and the distress and even elections or whatever it is. Those are everyday matters. You don't have to just label it or assume that you have to now ask a very, maybe even uncomfortable question to you, but it's acknowledging that care in today's context has exactly that, a different context. And unless we know that, and when you look actually at those that have been affected by unemployment, it's primarily women of color, Black and Latinas. And if we already knew, again, back to the numbers with the story, if we already knew that before there was a pandemic, already upwards of 70% of, you know, Black kids are being born into a mom that is unmarried and is carrying a lot of the load, and she is like the leader at home, maybe working 2 jobs and also volunteering at church and doing it all. And all of a sudden, maybe she's part of that statistic that lost her job. What does that do to your ability to keep it together? If some of us moms with our kids at home trying to like wing this whole remote learning are finding it difficult, imagine what it is for others. So it's asking the question in the context. I'd like to say also that cultural intelligence addresses the checklist of what does this mean in culture, in context, in language, and in market, because depending on where we live, that changes. And yes, it's the person. It's not the patient, it's a person. And he or she is going to be stressed out by what's happening. There's stuff I was reading the other day also about corporate professionals. I need all of us to also understand that this conversation is not the underserved, uninsured, you know, disadvantaged minority discussion. It's not that. It's not. You know, upwards of 80% of Hispanic and Black patients do have insurance. So it is cultural intelligence, not tokenizing or stereotyping disadvantages and assuming that the top barrier to care, like we did this with our big data analytics, what was the top barrier for diabetes, you know, care amongst Hispanics? It had nothing to do with access, but everything to do with the relationship with my HCP. So this may be impacting the very panelists that you're seeing here in the screen. So let's think about that.
And not only that. I mean, we know that lack of access know that it's gotten worse, and it is affecting some. I mean, I'm always pushed by our community manager, Cherie Shockley, who's telling me get back to the title and focus of the discussion. And Lili, these points are huge. And in the time of COVID, like, obviously there are many more people who are going to be unemployed, worried about being unemployed. I mean, this is just such an incredible time of uncertainty, even if you have, as you say, what you have. But for all the people that don't, you know, Cherise is saying what specific actions are being taken to increase healthcare options and support reduce costs of healthcare. She's talking about medication and supplies, and also stuff that improves the quality of life. So I don't know if you have some thoughts on that. I want to ask that as well because, you know, Chris Memmering out there has said, you know, it totally depends on the provider, you know, in a very rural area where offices are closed. Even this piece on telehealth, which we do know a lot has reduced barriers for many people with diabetes, but he also has a provider who's like, yeah, I don't think so. You know, I don't want that. So these, I'm kind of just bringing up some of those things. If you guys can touch on them about the patients that have way less or have providers that don't necessarily agree with where you and we would all like to see people go.
Well, so I'll start.
Thank you.
So it's going to be those, or you're always going to find pockets of those that are somewhat resistant to adopt whatever the level of change is. And I understand telehealth and remote patient monitoring, that is a change from what someone would perceive as the norm. What we're always going to focus on in UnitedHealthcare, and I'm sure it doesn't matter who's sitting here, they're going to say the same thing, whether it's Aetna or Cigna or Humana or anyone else, the Blues. We're all going to say we're going to focus on evidence-based, high-quality care, and that's what we're going to promote and encourage. And if there is a provider that doesn't or isn't leveraging whatever is necessary to be leveraged to provide evidence-based quality care, that we're going to work with you, the individual, the patient, the member, to seek out care from someone that is going to provide that kind of evidence, quality care to you. That's our promise to every single one of the members that we serve.
Yeah, love that, especially because the evidence is getting a lot clearer, and there's evidence from fancy randomized controlled trials and also evidence from real world data about what all of us are experiencing out there. Let's see, other thoughts on to follow up what Michael said, Conrod or Lili. I'm going to be moving to our final question in just a minute, but I want to give you guys that opening.
You know, I think what Lili said earlier was super important, which is that you have to just really be able to have the cultural context to be able to solve these problems, because they're so multifactorial. I mean, especially working in social determinants, we think it's easy to say, well, someone is just having health literacy issues, but it's no, it could be housing, food insecure, health literacy, and economic instability. And so there's a lot of work that needs to be done. But I think what somebody mentioned earlier, so much of diabetes, especially if you want to go down the prevention route, it's behavior modification, right? There's so much that we don't understand about obesity. There's so much that we don't understand about, diabetes, and not just we as, on this call, but we meaning I'm speaking from the community, right? That the first time you're really getting any kind of education about this is when someone is either diagnosing you or misdiagnosing you with the condition, and that happens, quite often. And so I think that, the opportunity is really about building those connections back in the community, making sure all the education is health literate, making sure it's coming early, starting, in the schools, getting back to teaching about nutrition and teaching about health and teaching about healthy lifestyle decisions that can hopefully get us to a place where this isn't an issue. And I do think, I don't think anyone in the pharmaceutical industry can say that they aren't thinking about how we need to think differently about pricing of medications and access and affordability, right? I think that's something that is going to continue to evolve. And I think some of the discussions that have happened recently have allowed for there to be more transparency about how those things are actually determined. But there's also a lack of awareness of a lot of the tools that are available to be able to support people that who may be in need of some of these additional resources. And I think, when I get back to it, and I saw someone mention, clinical trials, man, if we don't fix this trust issue, we're going to be in a world of issue because of hurt, because as Lili mentioned earlier, we are rapidly racing towards a majority minority country. And the strain that that's going to put on our healthcare system and our economy is significant, because the Hispanic population, the African-American population, are disproportionately impacted by diabetes, heart failure. They have lower immunization rates. You think about cancer rates, prostate cancer, breast cancer. I mean, if something doesn't change, something is going to have to, something's going to, serious is going to happen. And so I think that it's difficult and it's frustrating. And I know a lot of people in this call have probably been doing a lot of work, but it's about continuing to do the good work, and it's about socializing, what's working. And I think it's also about being thoughtful about the information that's being put out there, because as we've seen in our political system, there's a lot of misinformation, and that happens in healthcare as well. And unfortunately, it takes even more work to be able to overcome the damage that's been done by misinformation.
Yeah, I mean, continuing to build a boulder of goodness uphill. All of you are doing that. And I mean, for all the people with diabetes, I mean, I found out recently that there are like half of us that aren't getting our eye exams done on time. Someone said to me, when's the last time you asked your doctor, how much protein is in your urine? I mean, I don't know, like not lately. I never learned that. I think there are some really cool things for us to be learning as we get to kidney health and heart health and all of that. Like there should never, ever have to be any of us in the hospital for DKA, because everybody should be able to get next generation glucagon. Everybody should be able to get all of these pieces that are related to prevention and preparedness. I might just ask, just on a final question, and I hope everybody goes back to the session rooms after this, and I hope our speakers do too. God, we're just getting really into some good stuff. This whole conversation, and especially pointing us toward racial justice. We have a lot of thinking to do about that, in particular at diaTribe, and I think my whole team, for always trying to get us to the things that are the most important and the most impactful and also feasible. What would you kind of say, like, with this audience here, what's step one? What do you most want to see next? And just from all of us, I know the whole group is joining me in thanking you for being here with us. But what would you like to see as step one for the diaTribe community who's with you right now? We might start with Lili and then go to Conrod and then end with Michael.
Oh my gosh, where do we start? I'm going to keep it simple. Be an ambassador for the knowledge you've gathered. I feel like when we have these conversations, you get some of these new numbers, like 100% of population growth is diverse, or this weird 80% of outcomes are things that have nothing to do with clinical care. So now that you have that, I'm going to give you like the Spider-Man command: with great power comes great responsibility. So just, if you share this with one colleague, loved one, or person in your community circles, that's already progress in my mind. We can wait for big things to come from payers, big pharma, DC. That's going to take a long time, but there's opportunity for a groundswell from the bottom up, and it starts with people like us. So just be a megaphone.
Be a megaphone. Love that, Conrod.
Yeah. Well, that's a great one, Lili. Hard to top that one. What I will say is that stories are really what empowers and drives change. And I think about, I always talk about Martin Luther King, and he gets quoted often during these moments, but how one man's dream shook up a nation. And so I think you don't have to wait for another person. You can be that. And so uncover, learn someone's story, tell your own story, because those stories are really what drive change. And Kelly, that's what you and I did. Was we just created a platform for other people to tell their stories. And it's amazing the amount of lives that has touched and how people have adopted new behaviors, because finally they said, I see someone who looks like me, who sounds like me, who I believe understands me. And if they can do it, I can do it too. And so I think there's just an amazing power that we each have. And there's such a great power within the stories that we can share and tell.
I know we're close to time, so I'll summarize by saying collective demand. I don't encourage any one of you listening here or those who listen to this recording to try to go after this and make requests and make demands and drive for change by yourself. Do it as a collective, because as a business and as business is, we respond to consumer demand. So if you can work collectively and drive a demand that's appropriate and cost effective, businesses will align and businesses will adjust.
Love that collective demand. We're listening. Be a megaphone. There's so much that is going to come out of this into what we're going to spread the word at diaTribe. Our community manager, Sheree Shockley, is going to have instructions for all of us. We're so grateful, Michael, Lili, Conrod, that you took time this evening to learn with us and to take time with diaTribe. And, everybody's out there, your questions and comments and interaction in the sessions were really inspiring. And another reminder of the power of community and the power of partnership. Conrod was saying, of course, we just, are so grateful to spread the word, and please help us do this. Once the recording is up, help us share it on social. Please hang out on Hopin for a little while if you can. You can go back to the sessions. That's a tab on the left-hand side of the screen. We're going to really dig into some of this, debrief some of the panel topics, and be able to connect with each other. You can also go to the expo hall. That's also on the left-hand side of the screen to check out some of the incredible sponsors who've helped make today happen. We're going to try to keep these rooms open for longer than just a half hour in case we're all deep in conversation. But, join our newsletter if you haven't at diatribe.org/join. Follow us, Twitter, Instagram, Facebook. We at diaTribe are really sending you a lot of love and based on Lili and Conrod and Michael, I'm sending you a lot of power too. So thank you so very, very much.